Okay, we're going to go ahead and get started. You guys are troopers. The folks that are still here are real troopers. Hard late in the day. You know, as a practice group, when we talk about what our topics are going to be for this seminar, you know, we always like to talk about what I call the nerdy stuff. You know, the legal rules and requirements, and all of that is important. But really, a big part of what our clients are, even just this morning before we came here, you know, in a meeting this morning talking about, man, our health costs are going crazy. What can we do to help reduce costs? And so there's a compliance aspect to healthcare reform, and then there is also and they're kind of weaved together. There's another piece of it that is focused on maybe some strategies for cost containment. And there's all sorts of, I describe it as there's a bunch of different levers that can be pulled to save money. Some of them you may not want to do, but some may make sense for you. And so we thought it would be good as a firm and a practice group to bring in, you know, Premier Source, the consultants, health consultants, to talk about some kind of common cost containment strategies that they're using and some of the things that they're seeing to maybe give you some practical ideas of things you should be looking at to try to reduce your costs. So we've got Tia Corley and Todd Nees, both from Premier Source, and we're going to go ahead and jump right in.
Brandon, I know last session they really focused on the changes in healthcare reform, and the one thing we really haven't hit on much is what's the cost impact. Unfortunately, we haven't seen much coming out of healthcare reform that really is doing much of anything to help save money or dollars. I think it's done a lot of things, but certainly not that at this point. And so today we wanted to talk about we titled it Cost Containment Strategies because we make a big distinction between cost containment and cost savings versus cost shifting. I think in the past, a lot of what we've looked at, plan design changes, how do we shift costs to save the plan money? Today we're going to look at more long-term strategies that will help hopefully save both the employer and the member dollars. And so some of the strategies we're going to talk about are not immediate strategies. Some of them will be plug and play. But some of them are going to be complex, and we really wanted to focus on some of the newer strategies, things that maybe you've not heard of yet or that are maybe kind of new to the market coming out of this health reform environment. But to Brandon's point, the first thing, fully insured plans right now, there's a $95 billion health reform tax and fees that are being passed on to the insurance carriers. And if you're fully insured, that is immediately being passed through to you. And so a lot of you have seen that in your renewal increases this year. Coming out of 2014 is when that hit. And initially we didn't know how that would be passed on. It looks like it's 100% being passed through. We're seeing anywhere from 5 to 6% of a renewal increase tied just to that before trend is even applied. So fully insured plans are really being hit hard. Some other things that we're seeing that impact both fully insured and self-funded plans are at the provider level. The healthcare providers out of the Affordable Care Act, meaningful use requirements have put a lot of pressure on physicians and hospitals to comply with certain technology requirements under meaningful use. So they're basically being asked to do more with less, which creates an environment where, again, they're still having the same costs that they've always had. They've got to figure out how do we cover those costs. And so to both fully insured and self-funded health plans, that means additional volume that's coming through the providers. They're having to get more creative to stay up with those revenues that they had before. The Medicare reimbursement cuts are impacting this. And then on the pharmacy side, just great timing, you know, with everything else, we're seeing just an influx of biologics and specialty drugs that are really driving up the pharmacy costs. So these are things that are affecting both fully insured and self-funded plans. And we're going to talk about some strategies around all of that today. Mostly this is just a real simple graph to remind you all from the standpoint of traditionally what we would be looking at when you get that renewal or when you're planning for the future. Most of the strategies would involve negotiating that fixed cost component. And we'll talk about that briefly. That's important. But the real issue is how do we impact the claims and how do we truly save dollars instead of continually having to cost shift through plan design, raising deductible. That's easy to get immediate savings. but is it really savings or is it just a cost shift to your employees? And so everything we're going to talk about today is really going to focus on how do we drive that claim spend down, and what are we seeing out there just in this environment, some of the newer strategies.
And clients will often call and say, we want to talk about increasing our copay or deductible or the premiums even, to the employees. And that's all fine. That discussion, there's some value in that discussion. Sure. But I always say, yeah, we can talk about that, but really what your consultant should be helping you with is the claims, which is what they're going to be talking about.
Yeah, and one thing to add to that, we had this discussion actually this morning. When you look at shifting that cost, or at least moving those benefit plan designs back onto the employee, you're going to have them pick up an additional share of whatever that cost may be, co-pays, co-insurance, deductible, something along those lines. There is value in that from just staying within, from an inflationary perspective, maybe just keeping track with where inflation is going, where medical inflation is going. So making incremental changes is not always a bad strategy. So when we talk about this, we're not discounting it or disregarding it. We're saying that there's something that we're looking at from a bigger picture perspective, a claim spend perspective, which we'll talk about that in greater detail. But I do think it's important to kind of say, what are some of those incremental changes that could be made within your plan? Doing that, or at least having that discussion as a strategy piece just to keep up with inflation. So then when you do have to make that change, it's not a full, huge hit at one time. So that's another thing that you might want to think about.
Sure. Yeah, we definitely don't want to discount plan design at all. I think we're just now looking at, if we were, kind of talking to you all, the plan design strategies are things that you've already tried in the past. This slide really speaks to what have we done historically when you got that renewal. If you were fully insured, you were going to go out to market, get several bids, have your broker bring back in the bids and look on the spreadsheet and try to see what's the lowest cost on the spreadsheet, and then make a decision from there. And you're pretty much fully trusting that the provider that you're with or the broker that you're using is going to negotiate the best deal, and that's really the limit of control that you had over that situation. If you were self-funded, some of the things you would look at, making sure that we have case management in place. So we want to make sure that, when we have a large claim, that's being case managed well, that they're being admitted timely, that they're going to the right provider, etc. But what we're going to talk about is more things that are going to bend the cost curve. Case management is great and it's important to have it, but it's not necessarily affecting your cost curve because it's after the fact. So a large claim hits and then it gets managed. What are we doing about the claims before they hit that? Also, another traditional strategy would be, let's go after the best PPO discounts. We want to make sure that we're going to spreadsheet that and we're going to get the best discounts. And so we would make decisions based on getting the best discounts. We might give up flexibility, we might give up control, but we felt like this is great. If we have 60%, 65% discounts, then that's what we're doing, and that's how we're going to save money. And I would ask if any of you, even that have that type of model, to raise your hand if that alone has saved you or reversed your trend or caused you to go backwards in your trend. I think we all know that that's a great piece of the pie, but it's not necessarily going to bend your cost curve. And then chasing the fixed costs, we all know that's important, but it's such a small part of the whole. So definitely that's something that historically it's still important, but it's not going to really bend the cost curve either. And then a big one, I mentioned the pharmacy piece with the biologics coming out. The traditional model on the pharmacy side really had its place, and it may still have its place in certain circumstances where it was real convenient just to go get your pharmacy and your claims, your medical claims, everything in one bundled place, where again you were trusting that that's going to be the best deal that you could get. We're seeing, and maybe you would chase after rebates because you wanted some rebate revenue, and maybe you wanted a discount off of your administrative fee in exchange for putting that all together. That used to be, again, it still has a place, and maybe it has a place for certain employers, but I think what we're seeing is that now with all the increase in even the pharmacy trend and the specialty drugs, it's almost not enough to just trust that it's being done, and so we'll talk about some strategies there. And then the other piece, historically, that we see that we think is maybe not necessarily going to help impact the cost long term is having wellness programs where we really don't have a way to measure the ROI, or we're not necessarily integrating the claims data or looking for gaps in care. We're just kind of putting our dollars toward a wellness program that's not necessarily targeted. So I think on the go forward, we're painting the picture for these are some of the things we've done historically, and there's still a place for all of those things. But I think in order to keep our costs down based on what we're seeing now in the provider community and what's going on, it's going to take a lot more than that.
You know, one thing we have talked about before on the wellness piece is not to say that again that it would not be valuable. I think it's something that we all need to consider and need to keep as potentially as a strategy. Many of you probably have those situations where you've heard of that one particular person that never knew their numbers and now they know their numbers, and that's a good thing. And maybe it gets them to the doctor in kind of a somewhat of a very dramatic moment. You know, kind of a person that goes immediately, gets a number, and finds out they're kind of a walking time bomb. And there are examples like that. I've heard that from other employers and other clients that we've worked with in the past. There are those particular types of situations, but as Tia's talking about with bending the cost curve, it's how do you get that particular member to take that report and develop some type of behavioral change with that data. So they have the data in their hand, they now have their numbers, what are they going to do next? And most of the time, not all the time, but many times we find that employees in that case, don't necessarily make those particular changes that they need to if they're not fully engaged. And as Tia mentioned, the actively engagement part is important in these particular situations.
And I think to speak further to that active managed piece, what we're seeing is that, again, historically, a large claim would hit, you would manage that large claim, but nobody was looking at the variances between the smaller claims that add up over time, and we'll show you some examples of those. So you were relying really on your carrier or your third-party administrator to actively manage those large claims, and they do a great job in many cases at that. But who's looking at all the rest of the claims that are adding up to that, just right to that stop loss limit that's really driving your trend? And so what we're looking at is when we can find ways, and we'll show you again how to do this and what we're doing to actively manage those claims, then in a way we have the dollars to subsidize when those larger claims do hit. And that's really the strategy that we're focused on. And then the pay and chase method, I think just being aware of that. When you are with a carrier that owns their own network, that's not necessarily a bad thing, but part of owning their own network, part of what their negotiation strategy is with those doctors and physicians and hospitals is that they want a deep discount on their managed care contract. So in exchange for a deep discount, then we're going to pay you very quickly. And we're going to pay the claim before we perfect it, and then we'll chase it later if it's not right. So there's a little bit of that, just understanding that dynamic when your payer is also your network. What that could mean is that maybe it makes sense to have a claims audit. And again, that's not right or wrong. It's just being aware that that's the case. If you're with an independent TPA, a lot of times they will have audit controls in place, or they'll perfect the claim on the front end before it's paid. Just two different methodologies. So in that case, you may be giving up network discounts in exchange for that, but both have a place. So just being aware of what that looks like. And then we've already mentioned kind of the bundled pharmacy. I think there the issue is that historically we've trusted that we can buy everything in one place and that the contract is going to be drafted in our best interest without really and again, not that it's not, but without understanding the role that TPA sometimes is playing and how much revenue is stopping there before it passes through to your plan. So when you hold your own contract, you can negotiate the terms and again, just get some more favorable strategies that are going to impact you, where the dollars are passing through to you versus stopping at the PBM or the TPA level. And this is just an example of what we're talking about around kind of managing the claims that are up to the stop loss limit. This gives you just an example of what we're seeing. Traditionally, that $225,000 number is something that would hit the radar of your case manager. If that was one claim, it would be on the radar all day long. But looking at this, if the expected cost for a certain episode was $1,000 and the actual cost is $2,600, the variance of $1,600 is not hitting anybody's radar. That's just extra that's coming through as a claim. But when you extrapolate that out over 139 episodes, that's worth $225,000 to your plan that could have been affected, but wasn't. And so part of the strategy with the passively managed PPO networks, again, they have their place, but part of their strategy is to get as many providers in the network as possible. So it's been a very broad-based strategy. Let's get everybody in, and we get deep discounts, which is great, but we're not necessarily caring about which provider you go to once you're in that network. And we're not paying attention to the fact that Hospital A is charging thousands more for this procedure than Hospital B, and there's just no steerage. And so I think those are the opportunities that you have as employers that we'll talk about implementing some steerage strategies, even inside of an existing network or doing direct contracts outside of that. So there are opportunities on both sides.
And see, one thing I would add to that is that when we look at that from the previous slide, the case management versus actively managed model, many times in a case management perspective, case management's good, and be able to have someone that directs that, as Tia had mentioned, case management's after the fact, so the claim has already taken place. Now it's trying to find out what's the best course of action there. Sometimes in a case management moment, and this is, again, not to make a general statement, but it's also just to kind of recognize exactly what Tia had mentioned, they're working within the system that has been built within that PPO network. So maybe they're talking about making sure you're going to this particular provider or a particular hospital within the PPO network, and yet that not necessarily is the most efficient or the most cost-effective place for them to be going. So the actively managed piece is kind of getting on the front end of that claim, obviously before it happens, but also from the provider perspective as well. So it's taken a little bit more of a hardline approach in that particular perspective. Nothing against case management, but they are working within maybe some inefficiencies within their own system that we all have never been aware of until some of this information starts coming out.
I think one other thing to be aware of that affects all of us, fully insured, self-funded, and the reason we reference both, I know we've got a group here, pretty broad group, both fully insured, self-funded plans. On the fully insured side, some of the strategies we're talking about may not be accessible to a fully insured plan, but I know Todd's going to touch on some of the fully insured strategies in a little while. But the claims affect all of us, regardless if you're fully insured or self-funded. And one of the things, there's a new coding system rolling out. So we've been operating under the ICD-9 structure for diagnosis codes. That's rolled out to an ICD-10. So we're going from 11,000 codes to 87,000 codes. Why does this matter? Why is it important? Think about the mapping of that. When you go from existing code structures at the provider level, even to the TPA level, is your TPA prepared for this? Are they going to be able to perfect the claims? Are they going to be able to process the claims correctly? And what's the likelihood of possible miscoding or coding errors? And so, again, this more just speaks to where we're at, the environment we're in, and the opportunity for waste, fraud, and abuse in the system, and the importance of having potentially a claims audit, or making sure, asking your TPA, what are your audit processes? Are you ready for this? How are you addressing these changes? This is just a real simple example that really speaks to, and this is on the procedure codes, but for the very same service, just an office visit, depending on whether you're there for 5 to 10 minutes or 11 to 20 or 21 to 30 minutes, there's a different code. And it's a different revenue for each code. So think about just the addition of all the different codes and just the opportunity for errors and oversight there. It's more of just an awareness to say, this is something to pay attention to. And even if you did your own manual claims audit or did kind of a random sampling, or educate your employees on paying attention to their EOBs so that they're making sure they're not getting coded for something that a service that wasn't performed. On the network side, again, we talked a little bit about discounts not necessarily being enough to bend the cost curve. Within the same network, we see such variances across the board. And so we talked about the pay and chase model, and then employers really considering what % of submitted claims end up as paid. So if you're in a model that's really more of a pay and chase where they're paying every claim that comes through, one way to kind of check that is to see how many claims are actually being paid versus how many claims were submitted. And that percentage, you don't want that to be 100%. This is just kind of a snapshot guide. It's not an exact science. But if all of the claims coming through, then that gives you, that's kind of a way to check and balance whether or not this is something you need to have audited or that you might want to take a second look at. If it's a very high percentage of every claim that is submitted is being paid.
You know, what's interesting is and T and Todd can speak more to this than I can, but even as a law firm, this is something we've had to look at this year. And, you know, we moved to a different payer this year as a firm for our employees because of this exact situation T is discussing. You know, we want a TPA that's handling those claims properly. We don't want them paying claims they shouldn't be paying either.
Mm-hmm. You know, and the other thing in this environment too, traditionally we had to make a choice. You either chose deep discounts, and when you did that, you were having to choose kind of a bundled arrangement to get that. Because the deepest discounts were coming from the payers that were bundling everything. We've had some encouraging discussions with those payers. They're starting to recognize that they're going to have to do some things differently. They're getting a little more strategic. We think the market is going to be going to a place where there's going to be greater transparency, where you're going to be able to audit more of this. Employers are becoming more educated about it. There's also new competition. It's been a really long time since we've had competition on the network side. There's some new competition coming into Oklahoma on the network side, which may help balance some of that out as well. So when we talk about steering, I showed you the example of the variances between different providers. And so the question, you might say, well, what do you do about that? If we're looking at a $1,600 variance, or again, in many cases, I'm telling you, we've seen as high as a $70,000 variance for the exact same claim, depending on which provider you're with. So the ways that we're kind of looking at steering that, depending on what the network is, really doesn't matter. You can set up incentives in some cases to steer volume. So you would develop your own network, whatever your employer name is, employer preferred network. You still have that other network that's a wraparound, but you're identifying those providers that are creating the best outcomes from a quality standpoint and that are the most cost effective, and you're naming them to your preferred network. And then you're waiving copays and deductibles to steer members to go there, or you're reducing them, maybe creating a variance in the design there. We also, to steer volume to the right providers, will do a pre-registration process on pre-planned procedures where they basically fill out a form and say they're about to have this procedure. It comes through, and then they're basically then educated that there's an opportunity for cost savings if you go to different providers. Also looking at, Todd's going to talk a little bit about the central medical home model, where if you contract with a primary care physician and you're giving that primary care physician information about these providers and kind of he or she has access to that data, they're able to then steer to the right providers as well. And then there's a transparency tool. There are multiple transparency tools out there where if you can put tools in the hands of your members where they can go on and say, I'm about to have a knee surgery, they plug it in, and it gives them an indication as to which provider would be the best cost based on your specific plan.
And Tia, one of the questions, I know I've been to enough meetings with you guys, one of the questions employers seem to ask is, when we're talking about steering people from provider A to B, that from a cost perspective is more efficient, we're not talking about reducing the quality of the care either, right?
No, I think that's key. And along those lines too, we're also very careful, and I think employers should also be very careful. None of us want to be in the business of being a physician, or we're not trying to take on that role so much as just educate. So the information in the transparency tool and or whatever research you do to come up with your preferred providers is looking at both cost and quality outcomes. And there's a lot more information on the quality outcomes being reported now than has been historically.
As T had mentioned, we'll talk about the central medical home type of model. And some of you may be familiar with this type of setup, if you will, or type of situation. We found that there are some benefits to this particular type of plan, if you will. And I think from probably the most maybe at the lowest level of what that benefit might look like, you know, having some type of PCP system. Those of you who have been fully insured or are fully insured, maybe you've been familiar with somewhat more of a closed practice, if you will, more of a stronger form of managed care, if you will, where there's a primary care physician. It's almost a gatekeeper type of model. Still exists today in some other fully insured plans. For the most part in Oklahoma, we've gotten away from that. There are some benefits to that particular type of plan, though, to have somebody that does have that engagement piece with the members. And again, it would be more of a group of primary care physicians that are able to steer, if necessary, to the appropriate providers. The ones that are on an independent basis that are not attached to a hospital system certainly do have much more of a benefit to be able to make sure that that steerage is going where it needs to go. I think the key piece here, though, is care coordination. So when we get to a particular type of situation like this, where we look at risk triggers, if you will, having reporting data that shows that there are particular members within your population, with your employee base, that sees 9+ physicians in a 12-month period of time. That does exist within each one of our populations. See unique medical provider interactions 15+ in a 12-month period of time. Those types of to some degree, again, almost not integrating the whole process certainly shows itself, and you'd have to think that there would be a lot of waste in that particular, lot of abuse of the particular system. And there's an article recently in the Daily Oklahoma about pain addiction. So that's kind of where most of us go when we think of all these different providers. It's almost like a doctor shopping moment, right, for pain medications. And there could be something similar to something along those lines. But I think at maybe more of that no one's trying to kind of game that type of system, even looking at it from the perspective of just the care coordination in and of itself. There's drug interactions that one doctor's not knowing what the other doctor is doing, those types of things. So you can see a lot of waste in your particular system. The central medical home model does do a very good job of eliminating these types of situations. So you have one particular piece of that primary care moment. If all of medical care was just catastrophic, if we could say, and some of those things that we talked about with surgeries that Tia was talking about, if all of medical care was catastrophic, then we could say that the 80-20 rule does apply. Certainly you have a certain segment, a smaller segment that just deals with larger claimants, and that's what we need to focus on. The issue, though, is, as Brandon brings up, and as so many of you have heard today, with affordable care, we have to have some type of plan in place, right, for those preventative type of situations and covering those claims that might fall below a certain dollar amount. As Tia pointed out, there are claims that fall below a certain catastrophic dollar amount that no one's taking a look at. But if we had some type of central place where there's engagement with the physician, where the physicians are reaching out to the members, getting them in for particular follow-ups if need be, if they're a diabetic and need to have certain follow-ups that just aren't taking place if they're not coordinated somehow, these things can be beneficial. So these types of population risk triggers, too, make a huge difference. When we talk about those risk factors, we talked about the wellness piece earlier, and the wellness piece, again, certainly has a place. This type of information, when you're able to identify 3 particular points of a metabolic syndrome perspective, looking at this from the perspective that if individuals have situations similar to this, and I don't want to point out the one that I fall into that category, so I won't do that, but I have one of these as well, so maybe some of you do as well. But these type of situations, the general consensus is when you have 3 out of the 5 of these particular conditions, then you're at risk for something a little bit greater and something that's going to maybe present itself down the road. So maybe it's not a claim that's happening today. It's not a claim that is showing up that is a risk factor, but it might show up down the road. And so how do we get ahead of that? So to Tia's point earlier, how are we actively managing this piece? Case management takes place when that claim has occurred. So now we're at the back side of the claim, it's already taken place. How can we get on the front side of that and fully bring into play the wellness piece in a good way, as well as care coordination with those types of central medical home models? So the potential impact for those particular conditions, so you have 3 out of the 5 of those risk categories that we just showed, 725% greater risk for diabetes, 276% greater risk for cardiovascular disease, and so forth. So I don't think any of these numbers necessarily are surprising, but I think from the perspective that you all take from an employer's perspective, how do we address this? How do we get ahead of that particular cost curve situation?
I think, Todd, one other point on that is, a lot of you are already doing biometric screenings, and so you're gathering that data. But we see a lot of employers running those separate and apart from almost their health plans. So there's no integration of the biometric data into the claims system where we're identifying high-risk members based on both the biometrics where the claim hasn't happened yet and the diagnosis that the claim is, they've already been diagnosed. And then, to Todd's point, pushing that data back to the primary care physician in lieu of a lot of what we see is the telephonic outreach, where there maybe isn't quite the engagement. But when you can put all of that together and have a central kind of coordinator through that central medical home, it becomes impactful, and we're starting to see a great ROI on that.
Yeah, I think from our perspective, what we'd say to each and every one of you, these are strategies that can be considerations. I think in every situation, everybody's different, everybody's culture is different. What would fit within your own particular population base? Where are your employees, and does that fit to maybe direct someone to a place such as this? So when you're looking at a self-funded arrangement, as I mentioned before, we have fully insured plans that have seen models like that. So models like, again, more of a stronger form managed care model. And now when you have something like this that's an independent model, self-funded plans can also maybe see those benefits of, again, having that care coordination, pushing the data, so gathering data, being able to have data that those systems are able to gather, having that data at your fingertips and being able to push it and then make decisions off that data versus something that is not maybe more anecdotal, not in a good place. So you're not taking it from a good position. From a particular claimant perspective, from type 2 diabetes, what do these costs look like? And these are slides, again, or maybe numbers that you may have seen before, and maybe you haven't, but particularly for diabetes and cardiovascular. And again, this is the result of getting ahead of those particular claims. So if you have a claim that kind of falls in these types of situations, you have a claimant within your employee population, a type 2 diabetic will cost $11,579 per patient. So if we have 27 in a 500 life group, this is an example based on a 500 life group. So in a 500 life group, 27 people generally will have that particular condition. You'll have to have 105 individuals that will have to have no claims at all in order to offset the dollars that would be spent for type 2 diabetics. Cardiovascular disease, $10,428 a patient. 85 people would be affected with that particular disease. We'll have to have 296 people that will not have any claims at all to offset that particular cost that your plan's going to endure. So when we look at fully insured strategies, this part here, and it depends too, as T had mentioned, every one of you come from different places. So some of you are going to be fully insured, others are going to be self-insured. What does this look like? Fully insured obviously limits the amount of information and the amount of strategies that you can put in place. So what we're looking at here, what we're trying to encourage is getting as much information as you possibly can, and look deeply at the underwriting factors. And so when we see so many of these strategies that we talked about before, many of them are going to apply to a self-funded plan. Well, from a self-funded arrangement, you have more avenues to go down to control those costs and contain those costs. Fully insured, you've sold your policy, you've purchased a policy from an insurance carrier, and they're going to tell you what they can and can't do, what they're willing to do in a sense. What do they have within their particular plan? So how do you fight back in a situation when in a lot of ways your hands are tied? Knowing the information that you can get can help you, and at least help you in making the decisions that need to be made. Demand the reporting. So obviously the reporting that all of you should be getting, depending on your size certainly, and if you're less than 50, things will be quite a bit more challenging to some degree. But certainly if you're over a particular size, you can get a premium to paid claims loss ratio report. That type of information is available depending on your size as well. We'll also give you a sense of how credible is that information. So that is going to be something that in making that demand, each one of you would have to look at it individually as it relates to your particular plan, your particular situation. Get a large claim report. Top drugs by as far as what's been paid, giving you a little bit more information in those particular types of plans as well. So all this data will help you, but again, your data is going to be limited. The size will determine what that limitation will give you as well. So these are situations too when we look at fully insured plans and we look at what that underwriting might give us, the underwriting strategies might give us. Know your pooling point and what those pooling point charges should be. We see pooling point charges from the perspective of 5 to 6% of the overall premium, but also go a little bit deeper, try to find out what is maybe premium tax, what's assigned to premium tax as far as your fixed costs are concerned. You'll see fixed costs probably in a variety of different terminologies that are listed in the underwriting worksheet. Retention fees, retention itself might be listed as where those fixed costs are. So you getting that data, or at least understanding where it's coming from, will help you in just understanding the process better. I will say that, as we go through this with some of our clients, we had one recently where from their particular perspective, and we went back to the underwriter and just simply just asked, what kind of situation are we falling in here? We're usually seeing a pooling charge at this level, or we're seeing a trend level at this level. And from their perspectives, it's kind of like, well, that's great. This is ours. So we appreciate you acknowledging that, but this is ours. But it does give us a place of negotiation. And I think that's where we're looking at this, as far as just at least knowing your information gives you something to start talking to them about. And certainly if you're able to give cases that or say, well, we kind of feel like that pooling charge is a little bit out of line, something like that, then at least that dialogue can start, and sometimes that builds credibility with those underwriters. It never hurts. And so that certainly is a place that could be helpful within fully insured plans. Know what the credibility factor would be in this particular renewal, or in your renewal as well. Again, as Tia had mentioned in a meeting that we had earlier today, that size is important. Size is important to be able to determine how do they view you? How credible do they view you? Meaning that if you're a particular size, if you're over 500 lives, they feel like that's 100% credible. That underwriter should be able to determine what that claims cost is going to look like to the best of their abilities. But the more people that we have involved, the more we're able to spread that risk, the easier it is for them to determine to 100% of the group itself. So your claims experience, for the most part, stands on its own. The smaller that you are, then they start bringing in their manual rates, and so you're rated not just off of your own claims experience, but you're underwritten off of their manual rates. So then it kind of gets back into how do they view their own book of business? How does Blue Cross Blue Shield, how does United Healthcare, Aetna, Cigna, how do they view their own book of business? So now the manual rates are going to start impacting you. And that hardly seems fair in one sense, but it is a situation that we're finding ourselves in.
Todd, maybe as a rule of thumb, we didn't put this in there, but it's good to know if you're fully insured, generally speaking, for every 100 lives, you're about 20% credible. So once you get to 500, then they consider you predictable. So if you look at your renewal and you had a bad claims year last year and they're using that to project your renewal, and you were 20% credible last year and you're 100 lives and you're still 100 lives, and all of a sudden your credibility factor goes to 40, where they're putting a higher weighting on your own experience, then that's just a way to negotiate that, to identify that difference. So if you kind of know the rule of thumb, for every 100 lives, 20% credibility, you can kind of watch that in your renewal to make sure you're getting a fair shake at that.
Yeah, and when Tia brings that up, I mean, when you look at 20% credible, then they're basically going to factor about 80% on a manual basis. So on their line of business, then most of your renewal is based off of their book of business instead of what your claims look like. So when we start talking about claims strategies and so forth, the smaller that you are, it's more difficult to make those particular types of changes, and you are chasing what those renewals look like. And I think it is important to bring up from a fully insured perspective that if those of you who are fully insured haven't seen it already, you're probably about to. Meaning that towards the end of the year, fourth quarter, due to the impact, or at least this is kind of the speculation that we're seeing and that we're understanding, is due to the impact of Affordable Care, now we're going to start seeing those renewals come out for 1/1/2015. Fully insured wise, the kind of the conventional wisdom is about 70% of the groups that are fully insured are going to start seeing significant rate increases. So I think it is something that we all need to be very prepared for on a fully insured basis. Is what do those strategies look like? What's our next step going to be in preparation for what that might look like? Now that kind of also gives us a situation where 30% of you might see some nominal renewals, but that's kind of the overall conventional wisdom. So it's something for us to be aware of. I would say on this particular situation, this particular slide, the other point I would make is that trend factor. We've seen for the most part 6.5% from a trend factor perspective for most consulting firms, most actuarial firms. Trend factor is something, again, as I pointed out, we have seen some carriers, and I think this is getting ahead of, or maybe trying to get ahead of a little bit, the healthcare reform impact. Trend factors are starting to kind of vacillate a little bit and not sticking necessarily right to that 6.5. So you may see some things going forward that are going to look a little bit different than just the 6.5. So be prepared for that. Common myths regarding fully insured plans. Usually the thought is that it's less expensive than being self-insured, and for the most part that can be true on that initial basis. So when you see that, and we would want to say that this is general for everybody to say absolutely that this is a myth. There are others of you might say, well, yeah, it has been less expensive for us than being self-insured. I would say that over time, over a period of time, it's proven out that most of the time that self-funded plans do a good job of containing dollars to a large degree. But I think, too, the predictability is something that a lot of people viewed as a benefit of being fully insured. And there's no question about that from the perspective of being able to determine what that particular premium is. You know what it is. There's something beneficial to a large number, maybe, of fully insured plans of just signing a premium check and being done with it and not having to worry about the fluctuations. What I would say, though, in somewhat counter to that, would be to say that if you're self-insured and you feel like you're hemorrhaging money, many times that's on a budgeting end, not so much from the perspective that the plan is not set up correctly or that self-funding is not for you. There are plenty of situations where people have been self-insured and they were sold in one sense, kind of sold a minimum level of what that cost might be because it sounded good and it sounded attractive. But if you budget for something on more of a maximum end and then and you're able to set your budget in that particular way, you can see a lot of at least a lessening of that predictability as it relates to just fully insured. I think there can be predictability, especially when we look at how do you contain costs in a self-funded plan. You can contain costs with all the different dynamics that we talked about earlier, but those types of situations can help and establish that predictability. But then when you budget at a maximum level, again, you have that predictable cost. You know what your maximum level is, and then anything under that is a benefit for you. So one thing in particular to think about as it relates to self-funded plans.
And I think one thing I'd add, and they've already mentioned it, but keep in mind what Tia said at the beginning. If you're fully insured, the insurance companies are getting hit with new taxes this year, and they're passing those straight down to the employer clients. So if you're fully insured, you're paying an additional amount already just because of the taxes the insurance companies are paying. The other thing that I see listening to these two talk a lot is if you have a good year from a claims perspective, as a fully insured plan, your reward could be still an increased cost the next year. So if you're self-funded, at least if you have a good year and you're doing a good job of managing your employee population and claims, you're actually saving your own money.
And we are seeing more strategies come to the marketplace as a result of healthcare reform and even just the environment we're in, where stop-loss companies are underwriting smaller groups. And we also have captive insurance companies that allow employers to somewhat come together and do a collective buying of the stop-loss piece, which allows employers of 50 down to 50 lives really to be fully insured and pool their risk on the stop-loss piece. So definitely some new funding, I say new to this market for the most part, that are out there and probably worthy of your attention given where we're at just in the environment.
Yeah, to that point of the last bullet point here, as Tia had mentioned, most of us probably thought, for the most part, if I'm less than 100 lives, I can't be self-insured. That has changed a lot, and there are different opportunities now. I think healthcare reform has just catapulted that to where we are looking at different opportunities, different stop-loss carriers, different captive opportunities do exist out there. TPAs today will look at situations that are self-insured for groups that are less than 100 lives. And again, I will say this, maybe somewhat as a caution, we're not saying that this works for everybody. I think it would at least be something that all of these particular strategies should be evaluated. I think that's maybe the general consensus is that we're just simply trying to say, look at your own particular situation. There may be some reason, there might be some sacred cows as to why absolutely we cannot be self-insured or, for that matter, fully insured, whatever that may be. Just these are different things that you might want to think about. We look at this as far as just, again, overall, look at that particular internal underwriting piece. From our end of things, we do like to internally underwrite particular cases on a fully insured or self-funded basis. Feel like it gives you great information and great data. It's an educational process to go through. So internally underwriting and just knowing what factors go in to set the renewal is a big process, and also trying to get ahead of it. Proactively being aware of what that renewal is going to look like and being prepared for the renewal before it comes out.
And we're offering that training. I didn't mean to interrupt, but that's something we're offering through Premier Source. If you are fully insured and you just want to better understand how the numbers get on the spreadsheet, contact us and we'll be happy to set up a session or to come visit with you about that and get you some of that training.
A couple things on the fully insured side. We talked about the internal underwriting as far as takeaways for health plans overall, so fully insured health plans. Reevaluate funding alternatives. We talked about the captive piece. Depending on what your size is, from a fully insured perspective, it could be beneficial to, again, take a look at what those opportunities are. Is a captive operation, does that fit for you? Is that something that might work? Those are things that you might want to take a look at. From a self-funded perspective, different cost savings takeaways that we want to at least encourage you to take a look at. These are things that we talked about before. But provider performance monitoring, the slide that Tia talked about where there's a particular claim that runs from an actual perspective at $1,600, but from an expected perspective, what we see and what overall the prevalent charges should be within a particular claim cost or a claim code, but also within that particular area is $1,000 or $600 worth of savings. And then when that's extrapolated over a number of episodes, there's real savings there. So knowing who those providers are, I think, is something that's a big strategy for those of you who are self-insured. Direct contracting and value-based steerage plans. Direct contracting just from the perspective that, who are those providers? These are things, too, that are very important to make sure that you're evaluating it with your TPA, a PPO network perspective. These are things that you have to look at big picture, but we do see great value in directly contracting with particular providers that are more efficient, have great quality measurements, but are more efficient from a cost perspective. The biometric screenings as well, risk stratification, having that data. Once you get that data, then pushing it to either that reporting team or your TPA, being able to make decisions off that data. So when you have the biometric screening data, you have maybe a primary care group that can kind of address that. I think that's very important, but be able to push that data where it needs to go. And also a direct contracting situation as it relates to a central medical home that we talked about. So these are strategies, again, from central medical home, many times involved with fully insured plans. These are strategies that are involved on a self-funded basis, can help you, again, provide that engagement with your employee population. Also, from the perspective of negotiating drugs to the medical, Tia talked about that. What does that look like from the biometric, the specialty drugs? So we have biological drugs that are in place today, injectables, we have cancer treatment drugs, all of those particular specialties, those are becoming much, much more prevalent. How do you negotiate those? Making sure that when they go to the medical plan and you have a particular physician that's administering those and marking them up an additional amount, and many times significantly. So how do you address that? So be prepared to get data as it relates to specialty. We do see, and I know we're running short on time, but we do see a lot of information as it relates to specialty and generics. So there's becoming a bigger split. Costs are getting higher and higher. The offset as it relates to medical is probably a good thing because the costs are being spent on a drug basis, but those drugs are enormously expensive. So something for you all to think about as well.
Yeah. On the pharmacy side, I mentioned, again, if you're in a bundled environment, a lot of times you're not controlling your own formulary. So what happens is the manufacturers, as many of you know, are paying rebates to keep certain drugs on the formulary, and you're not really in control of that. So from a clinical management perspective, one of the things, I know a lot of you have probably already been tuned into, okay, we need to push generics, and we need to have some strategies to drive our members to generic, and you've done a great job of getting people to generics. And so the optimal generic distribution rate right now is around 80%, just so you know. If they were taking all the generics that they could, when they could, it's about 80%. But if you're not controlling your formulary, one of the strategies on that is have the member pay the difference if they choose a brand over generic. But to Todd's point, the biologics and the specialty drugs really aren't impacted there. So if you don't have your own contract and you're not controlling your own formulary, then you're put in a position where your formulary is going to be made up of a lot of name brand drugs, and there's probably not a lot of clinical management that prefers lower cost drugs to their higher cost alternatives. And so through step therapy, here's just a quick example of the rebate games that are out there. And so if you're somebody that has perceived rebates as a really good thing and you're chasing the rebate dollars, Nexium is just a classic example. Nexium is $250 a script. Prilosec over the counter is $35. It's the same therapeutic equivalent, or it does the same thing. The average rebate for Nexium is $100. If you don't own your own contract and you're just getting rebates, you're maybe making $3 on that, but it's on your drug. So the net effect to your plan is almost not worth chasing the rebate. So we just encourage employers to really look at opportunities to get the best net effect and to not necessarily focus as much about the rebate dollars. The other big thing to be aware of on the pharmacy side that isn't in here yet is the compounding. So when you have average wholesale price discounts off of certain drugs, compound drugs are new. A lot of pharmacists are issuing compound drugs where they're putting two different drugs together. And because it's a compound, it's not a drug that has an average wholesale price. So they can there's a lot of play in how they set that pricing. So there are a couple of drugs that, just as a takeaway for self-funded plans, it's VIMOVO and DUEXIS. And both of those are compound drugs that you basically, they offer real, again, it's just acetaminophen and another drug that they put together, and they're costing thousands of dollars to the plan. So, and I think we are getting close to being out of time. I think the last piece, Todd mentioned the importance of, one other takeaway for self-funded plans would be to ask your TPA or your TPA to run a J-code report, which is going to be all the drugs that are running through medical, and starting with the highest paid to the lowest, and start identifying opportunities there. As Todd mentioned, those are the drugs where somebody is going to their doctor, and that doctor is buying through his own wholesaler and then marking it up and passing it through the plan as a claim. Those are opportunities where, when you can go back to your PBM, find out the best pricing for that drug, and then go negotiate that with the provider. And they're negotiating all day long. We've had several, well over $100,000 cost variances where they've saved the plan. This is just one example of the providers being willing to negotiate that. And I think we're getting close on time. Are we good?
I think we're good. Finish your slide.
Yeah. I think, again, just some of the things, when you hold your own contracts that are important, you have the ability to negotiate the terms and to get the performance guarantees. If you've got discount guarantees, AWP discount guarantees built into your contract, it's important to know that you may or may not be meeting those. And so understanding in your contract, what are the true-up provisions if we don't meet that average wholesale discount? And how quickly are they returning the funds to us? So we have kind of some checklists for PBM contracts that I know Brandon has had a slew of them lately that we've negotiated. But if you're looking for those terms, those are some things we're happy to share with you. But the first step is really holding your own contract to do that.
I like to tell people there's a lot of dead bodies buried in the pharmacy stuff, and listening to these two talk, a lot of dollars that are being left on the table by clients.
Yeah, I think very quickly, and we plan on staying till 6. Are you all okay with that? We're just going to keep going. This is so much fun for all of us.
Todd is the son of a pastor, so a Baptist preacher.
We're just talking, right? You get an amen? No, no. Anyway, real quickly, actual case study examples. You all have these in your folders. The information just gives you an idea that from a self-funded perspective, this first slide is from a self-funded perspective. If you were to, what we've seen with actual clients, prior to actively managing the case and after actively managing the case, and you can kind of see the differences between these three different employers, 15% versus a 1% 3-year average with actively managing the plan, getting out ahead of those claims, being prepared to look at potential efficiencies, again, with better providers from a charge perspective. So being prepared to do that, 12% versus 0 and 22% versus 5. So just, again, taking more of of course, an active approach, taking a sledgehammer to this. Either we're going to address healthcare costs or we're not, and that all depends on kind of how people talk a good game until it gets to places where they really want to make changes like this, and then it's hard. And it is hard. It is hard from an employer's perspective. But when costs continue to go up, we've got to be ahead of this somehow. We just want to provide you some of these strategies. We have another case study in there which you can read as well. But we do appreciate your all's time. We just wanted to give you this information. Hopefully it's helpful for you all, whether you're fully insured or self-insured. But ask us any questions. We'll be around afterwards. All right. Thank you all very much.
Thank you.